Hi, my name is George Gentchos. I'm one of the thoracic radiologists at UVM. I'd like to say that I'm very pleased to be asked to talk at this conference. My topic is lung cancer screening, and it's a topic that's very near and dear to my heart in the thoracic radiology division. I've been involved in lung cancer screening since around 2000, or lung cancer program since 2004, diagnosing and treating lung cancer in the community. And screening has been something that's new and exciting in our field, so I'm excited to share our experience with you today and discuss some of the issues of lung cancer screening. Can I just get a sense of who's here? Are there some primary care providers? Great. And are there just some folks that are generally interested in lung cancer and lung cancer screening? Great. Okay, thanks. My talk is geared, for the most part, for a primary care audience, so I apologize for those that are not primary care physicians. I try to go into some of the details of who to select for screening and some of the issues that a provider would face in making a decision for screening, but I hope that there's some general relevance to everyone in the audience. I have no relevant financial disclosures. I should disclose that I'm fairly opinionated, and the other thing, when I was putting this talk together, with the recent passing of Yogi Berra, I thought of one of my favorite quotes of his. During one of the baseball games that he was at, some streakers ran across the field, and he was explaining this to one of his friends, and they said, "Yogi, were they men or women?" He said, "I don't know, they had towels over their heads." So I would like to disclose I don't know a lot about women's health care issues. I've been in the lung cancer and thoracic radiology field, but this is really a topic that I think crosses it involves women. It's a very important issue. Lung cancer affects women. It's one of the leading causes of death of cancer, and so I think it's a very relevant topic in a women's health symposium. Obviously breast cancer, I think it's more pressed than lung cancer, but when we look at some of the statistics, we'll see that lung cancer is really it's really a women's health issue and affects a lot of women. The outline of my talk will be to talk about some of the lung cancer statistics. I'll look at some of the case that was made for lung cancer screening, how that came about. Really, the biggest part of that will be talking about the lung cancer screening trial, which was the trial that pushed lung cancer screening to the forefront. I'll talk about some of our lung cancer screening program, how that came about, what I think are the elements of a lung cancer screening program, that if you're involved in lung cancer screening, things that you should look for in a program, and then talk about some of the issues and barriers to screening. I'd like to spend the majority of the talk talking about issues and barriers to screening, because that's what patients and providers will deal with mostly with this topic. There's really no way to talk about lung cancer screening or lung cancer without talking about tobacco, and tobacco engenders a lot of strong feelings in people. It has a lot of ill health effects. It causes a lot of diseases. There's a lot of controversial issues about smoking, what to do about smoking, who should pay for smoking. And I was recently in Central America, and I stopped at one of the gift shops, and they had these are cigars, not cigarettes, but this was in Costa Rica. This is the equivalent of the Surgeon General's warning. They put these very graphic pictures of smoking-related diseases on the cigarettes. I don't know if you can see very well, but there's someone with tongue cancer, someone who's died of a smoking-related illness. It's a very graphic presentation of what some of the potential harms of smoking are. And when we think about what are the results of smoking, obviously lung cancer is one of them, and that's actually one of the smoking-related deaths in the United States, of which there's about 443,000 per year. Lung cancer is about 29% of those. So when we think of smoking-related illness and injury, lung cancer is really at the top of that. There's other adverse effects, COPD, the risks related to stroke and ischemic heart disease, but lung cancer claims a lot of smokers. And traditionally, we really have had no way to look for lung cancers in smokers. We know that they're at high risk. We've told people to stop smoking, but we really haven't offered anything to say, do I have lung cancer? Can I catch it at an early stage? And so lung cancer screening is really important. Again, going back to my first talk about the differences between men and women, this slide is hard to see, But when you look at the cancer statistics, breast cancer is more common in women than lung cancer, but the death rate is much higher than breast cancer in women. So, boy, I can barely read that myself, but boy, can't even see that there. So, lung cancer accounts for 13% of cancers in women, but accounts for 26% of cancer deaths in women. And it's about equal in men now. So lung cancer is the leading cause of cancer death in men and women. With 224 new cases of lung cancer, 159,000 deaths. That was from 2013 statistics. It's really a staggering statistic of how much lung cancer there is and how deadly lung cancer can be as a diagnosis. When we look at Vermont, roughly we have 500 new cases of lung cancer a year and about 350 deaths a year. We're obviously a smaller state with a smaller population, but that's a relatively high number in a small state. This statistic is a little hard to see as well. I apologize for the graphic presentation, but what we're looking at is really the rates of smoking in women. And one of the things that has been instrumental in this graph, the blue line is the sort of how much people have smoked. It's the rate of smoking. Starts about 1900 and goes to about 1998. So there was a sharp increase in women smokers throughout the first part of the century. Peaked a little bit after World War II, and then there was a decline in the rate of smoking among women. This is the lung cancer rate. So this is one of the things that people correlated with smoking rates increased, lung cancer rates increased as well. So this was the lung cancer rate in women. This is the breast cancer rate, which has remained relatively steady. There was a decline towards the late 80s and 90s, which has been attributed to screening, and that's been declining. When some of these impact points in the smoking cessation, the Surgeon General warning came out in 1964. There was various ads that were banned from airwaves. There were cigarette taxes increased. There's been lots of cause and effect of why this smoking decreased over time. And this is the male incidence of lung cancer, which has peaked around 1985, has been steadily decreasing. The female rate peaked around 1998 and really has kind of slowly decreased. This correlates with the smoking rate. Men started smoking earlier and more than women, so we don't expect this to decline as rapidly, but there will be a point at which it's relatively equal. Now it's almost an equal incidence of lung cancer in men and in women. Just to review that again briefly, lung cancer is the most common cause of death in men and women from a cancer diagnosis. The good news is early stage lung cancer is curable, and the goal of a screening program is to identify early stage lung cancer. The problem with that is we have not had a good screening test. Again, at Fletcher Island, we had 228 new cases per year, but the majority presented with late-stage disease where the treatment is more palliative than curative. So what we noted was, again, this is a graphic representative of different cancers. So prostate cancer has a really good 5-year survival. Breast cancer has a really good 5-year survival. Colon is okay. Lung cancer has a very low 5-year survival when you include all stages of diagnosis. Your chance of a cure in an early stage is fairly high with lung cancer. So the early stage 1 cancers, stage 1A has a very high cure rate, stage 1 greater than 50%. But when you get into stage 4, the cure rate is much lower. The 5-year survival rate is much lower, and that's illustrated here in the graph. This is a stage 1A patient over time. And this is a stage 4 patient, so the cure rate is much higher if you diagnose this early. What we notice is, and what multiple centers notice, is that we do identify some people with early stage lung cancers, but it was really just serendipity. You got an X-ray or a CT scan, someone noticed a nodule on that, it was biopsied, it was an accidental discovery of an early stage lung cancer, as opposed to the majority of patients that presented with late stage lung cancer with hemoptysis, with weight loss and other symptoms related to metastatic cancer. And so there was really no way to screen for these patients until they had presented late with lung cancer. This was the experience. This is our experience in men and women at Fletcher Allen. 1,000 cases of lung cancer between 2008 and 2012. Blue are the women. I'm sorry, blue are men. Pink women. So it was, again, relatively even. In fact, we actually saw more women with late-stage lung cancer than with men. All this led to investigators looking for a way to screen for lung cancer, and this is the landmark trial that was published in 2011 in the New England Journal of Medicine. It was the lung cancer screening trial. The discussion of this trial would be rather lengthy to go over all the details of it, but basically they randomized people either into screening with a low-dose CT scan or with a chest x-ray. There were very large numbers. The randomization was good, 26,000 people in each group. People got yearly screening for 3 years, and then at there was a data collection period, so that went from about 2005 to 2008 where they collected data, and they finally published the results in 2011. But in patients that had 3 years of screening, either with a chest x-ray or CT, the lung cancer death rate was much higher in patients that were screened with a chest x-ray compared to a CT scan. This is a 20% relative reduction in mortality when you factor in the person years. So that was felt in the community of people taking care of lung cancer. This was felt to be a landmark study. It showed that if you screened with low-dose CT scans, you could detect early-stage lung cancers. You could influence the disease when it's curable, and that made a demonstrable impact on the mortality rate, even in a very short period. The downside of the screening test was that you screened a lot of people. You found a fairly high number of cancers. This is the cancer rate per person year, but you had a lot of false positive exams. It's a very sensitive test. The threshold size of a nodule was very low, so you had this very high false positive rate. So there's been some criticism of this, mostly based on the false positive rate, and then what are the costs to society if you were to screen people at risk for lung cancer. Again, what this study showed was that you could flip the curve that we were normally seeing. So most patients now are being diagnosed within the early stages of lung cancer. Red is CT screening, blue is chest x-ray screening. So most of the patients that were diagnosed with early stage lung cancer were diagnosed with CT, as opposed to later stages where both CT and x-ray can pick up cancers. So this flipped that curve that we were seeing when we didn't have any type of screening test, where we discover more late stage lung cancers. Again, this was very exciting to all of us in this field, because it gave us evidence to something we had seen anecdotally of, like, if we look for lung cancers, we can find them and we can impact the disease. So multiple societies after this study was released advocated for lung cancer screening in the general public based on the parameters that were set in that study. A certain risk of smoking. You smoked 30 packs per year. You quit less than 15 years ago. This was reviewed by the U.S. Preventive Health Services, and they eventually approved it and gave it a grade B. If you're familiar with the grading system, a grade B basically says they approve it with some hesitation. They've noted the false high positive rate. They broadened the eligibility slightly, so instead of 55 to 74 that was in the study, they broadened it to 55 to 80 years. And the grade B mandates that insurance pay for it without a copay or a deductible. This was followed about a year thereafter by Medicare also approving lung cancer screening as a covered benefit. That was around the early 2014 period, and that's when screening really started to become more prevalent. Prior to that time, between 2011 and 2014, when this was not approved by insurance, I think we screened maybe 5 or 6 patients when it wasn't covered. And then once the coverages came through, then we began screening more patients, and we've almost screened 1,000 patients since that point. General caveat about screening tests: there's no perfect screening tests. Like I said, I'm very opinionated because of the field that I work in. There's been criticisms of screening tests in general. I'm sure many people are well aware of the mammography screening controversies. Those also apply to lung cancer screening. There's pros and cons to any screening test. And I think when we talk about these, we need to talk to each other respectfully, and also understand what the downside of not screening is, and also acknowledge that. The pros of screening is that there was a reduction in cancer deaths by 20%, detected early lung cancers when they were most treatable. The test itself is safe and non-invasive. There was minimal need for biopsy, and sometimes you discover important ancillary findings using a low-dose CT scan. Cons I'll talk about in detail. the cost of it, the high false positive rate, it causes patients anxiety. You do find incidental things that need further workup, and then the questions of how much radiation exposure there is. All of these controversies led us at UVM to come up with a plan to address all these and say, okay, you know what, if we're going to do screening, we need to do screening really well. We need to form a screening program to address all of these concerns, because we don't want people to have either to not participate in screening in the general community, or to send someone into a program or to get a test that they don't know what to do with the results. So we formed a steering committee to form a screening program at UVM, and basically to model it after the results of the lung cancer screening trial. That trial was performed in 120 academic medical centers, and our goal was to mimic the sort of institutional elements of that program so that things are seamless when you have a lung cancer screening program. Myself and Dr. Garrison, a pulmonologist, are co-directors of that program. We enlisted a lot of stakeholders when we formed this in the community, and particularly our family practitioners, Dr. Peterson, Dr. Rep, are representing the primary care community, because we really wanted to get feedback of how would this work. We wanted to make this a seamless program, and it's been challenging, to be honest with you. We're a nascent program. We're up and running. We have a lot of enthusiasm. We don't get a lot of support, but I think we have a lot of enthusiasm. I think we have a really robust program. When I think of lung cancer screening, though, the screening CT scan is just the tip of the iceberg. It really has to integrate into a whole comprehensive program, which includes smoking cessation throughout the process. We integrate our screening program with our own follow-up system through through radiology, and then we interface with two other portions of pulmonology and lung cancer. This is the lung transdistillary clinic, and this is the lung nodule clinic that my colleague Dr. Garrison formed to address incidental findings, anxiety over finding pulmonary nodules. But really, we think of this as sort of, okay, the test is sort of your entry point into a system. We don't want people to feel, we don't want patients or providers to feel like they're just ordering a test and then a patient's going to be lost in some abyss. We really want people to have a scan, know that they're entering a program, they're in a safe harbor, we're going to follow up the results, we're going to get them where they need to go. And that's really been my goal, is to just make that a seamless process. Again, that's a little bit challenging. We don't have a lot of resources, but we do have a lot of energy. What I've identified as some of the elements of lung cancer screening program that I think are important. We have to have a program coordinator, and I'll talk about that a little bit. We sought some designation. This is the ACR designation I'll talk about. We use a standardized reporting system when we're reporting these exams. We have a screening system, and then I'll just go over some of the results that we've had to date. Our program coordinator, her name is Kassi Solace. She's a radiology technologist. Her job is similar to a mammography coordinator, where she interfaces with the directors, and she basically does a lot of the logistical work in our program. She tracks patients' results. She does the short-term and yearly follow-ups, make sure that patients get follow-up. She sends the result letters to patients. She addresses ordering and billing issues, coordinating with offices on billing and ordering stuff and follow-up, and then assembles all of our QA statistics. And having a live person do this job is integral to a program, because you have to have some redundancy. This is very high-risk screening, and you really can't, you really need to be very conscientious of how you do it and how you follow these things up. We applied for and received the American College of Radiology seal of designated lung cancer screening center. We applied for and received this in August of 2014. It's a certification that is based on review of the CT scanners or lung cancer screening program and the radiologists that are interpreting the scan. So at our institution, we have thoracic radiologists that are board certified general radiologists that have done specialty training in thoracic radiology, do all the interpretations for the lung cancer screening studies. And this requires some ongoing quality metrics. So we applied for, got that, and I think it's an important element to have in a screening program, because it says your equipment's good, your protocols are good, and your interpreters are good. This is a standardized report that we use. This is the American College of Radiology. This is the first version of their standardized reporting for lung cancer screening. It's called the LungRADS 1.0. It basically stratifies results into one of four categories. the fourth category is the ones that are the sort of high-risk findings, and those are subdivided into an A, B, and C. A negative exam is considered a Category 1 or a Category 2. Those are a lot of sort of incidental findings that you might see on a CT scan, small pulmonary nodules, other basically very small pulmonary nodules are basically considered a negative study. Positive studies are the Category 3 studies that are very low risk as well. And when we send these reports, we put the categories, and they used the data from the lung cancer screening trial to give a risk estimate of the category. So in addition to saying what category it is, it gives a risk estimate of, like, if you're in that category, what's the risk of having lung cancer. And again, those are very low, less than 1% for Category 1, 1% or less for Category 2. And again, it gives some idea of what the risk of category is when you do this. The advantage of the standardized reporting, it really forces the radiologist to make a decision about what they're seeing and to come up with a recommendation that is very clear. You don't want to have just a finding or have no recommendations in these reports. So this really forces us to make management decisions of what we do about this and what the recommendations are, and those are relatively standardized at this point. Talk about, you have to have a screening system. This is our not very complicated screening system, but it basically, when we have a lung cancer screening, there's various possibilities, and each of these possibilities has a direction of what's going to happen. So the current recommendation, if you have a Category 1 or 2 screen, is you get followed up in a year for annual surveillance. And I'll talk about later why we recommend annual surveillance. It's really important not to think of this as a one-time test. It really is a screening program. But those patients that have a Category 1 or 2 report will get follow-up in 1 year. And then all the others have different pathways. If you have a Category 3, those are very low-risk nodules. It's considered a positive screen, but they're very low-risk nodules. And so those can either be followed up with a short-term CT scan. We set up a mechanism outside of the primary care office if they wanted to talk to a pulmonologist about other management options. That's my colleague, Garth Garrison. This is his contact info and his coordinator. So if there's a patient that would like to has a positive screen, it's a low-risk nodule, but would prefer to follow in pulmonary clinic, that's the venue we go with that. The 4 category can either get another diagnostic test, a PET CT scan, another short-term follow-up CT scan, or a biopsy. So we make specific recommendations for that. And if we recommend a biopsy, we have a pathway through the lung cancer clinic that will get patients in quickly, get the appropriate biopsy. There's a lot of different ways to biopsy lung nodules via transcutaneous approach, via a bronchoscopy approach, and so we try to make those decisions, expedite that referral, and get those taken care of. This process, we've been in place since 2006 or 2007 and works fairly well. These are some of our results today. I gave a talk a couple weeks ago, so this is interesting. They have there's some updates within the last couple weeks. But as of January 2014, we performed about 639 exams. The majority of patients fall into the Category 1 and Category 2 categories. Very few fall into the Category 4. Those are the ones that are most suspicious. Our overall positive screening rate, that's the Category 3 and Category 4, is 11%. So I don't know if you noticed in that slide, the positive rate in the lung cancer screening trial was about 26%. So the question is, why is our positive rate so low? And I'll talk about that later because we've changed some of the thresholds on that. But this is in a screening program, this is a fairly acceptable rate for a positive screen. It includes the Category 3, which are very low-risk nodules. If you only include the Category 4, our screening rate would be lower. But it does capture Category 3 and Category 4. And to elucidate the point that we don't do a lot of biopsies based on these, of these 600 patients that were screened, we've performed 13 biopsies. And of those 13, 11 were malignant, 2 were benign, 1 was an infection, 1 was indeterminate but not malignant. And a large percentage of those were early stage lung cancers. 9 out of 11 were stage 1 and 2, again, that have a higher likelihood of cure for treatment. So some patients got cancer, some got radiotherapy with intent to cure. So this has been very exciting for us. We've seen more early stage lung cancers than we have since we've had a cancer program, or lung cancer program. We had 2 late stage cancers that had also have had fairly successful treatments, but we're seeing a lot more early stage lung cancers. In the 2 weeks since I put this slide together, we had 4 new diagnoses of lung cancer, all of which were early stage lung cancers. So we're seeing quite a bit. It's more than you would predict from the lung cancer screening trial. So we have, it makes me wonder, you know, in Vermont we might have, you know, an even higher risk population based on the amount of smoking. So I hope I've convinced you that smoking is bad, lung cancer can be bad, but we need to catch it early. And I hope you don't mind me patting myself on the back for coming up with a great screening program. So that's my first part of my talk. This is really the meat of the talk, where I want to talk about some of the issues of screening. These are some of the questions that come up from patients' perspectives and from providers' perspectives of what are the logistical issues of screening. First off, how do you order a screen? Basically, you can order it through a written order or through our electronic health record, PRISM. You just put in lung cancer screening in the order set. It comes up with a screening thing, which is the low-dose lung cancer screening. That'll prompt you to a fill-in field. There's some questions that will be asked for that. So the PRISM order is there. It's being modified now for the Medicare shared decision-making. So the Medicare shared decision-making questions will be incorporated into the PRISM order. For the codes that are used, these are the old ICD-9 codes. The new ICD-10 codes is the Z12.2, which is the malignant neoplasm, screening for malignant neoplasm respiratory organs. And the secondary code is the personal history of tobacco use. So those are the screening codes. Who do I order it for? The age range is 55 to 80. Medicare covers up to age 77. The high-risk screening is still 30-pack your history of smoking quit less than 15 years ago. Again, that's high-risk screens. And we recommend an annual screen while the patient is in that high-risk group. Should not have any signs or symptoms of lung cancer, namely hemoptysis or weight loss. Cough associated with COPD is not a disqualifier for lung cancer screening. Insurance now is, the insurance situation is very favorable under the Affordable Care Act. Plans that were not grandfathered cover it without a copay or deductible. Medicare covers it from 65 to 77 or when they're Medicare eligible. Traditional Medicaid is set by the state, but they are covering it in Vermont. There's a nice website on the American Lung Association that goes through covered plans. That's fairly helpful. If you follow the link to lung cancer screening, there's a link on insurance coverage that's fairly helpful. This is the rather lengthy Medicare shared decision-making requirements. So they've approved a shared decision-making visit. These are the elements that need to be documented to proceed with lung cancer screening at that shared visit. Obviously, it's very difficult to read this, but it basically goes through that you've talked about the risk and benefits of the procedure, and that they will talk about smoking cessation, that they will stay in the program, things of that nature. So one of the problems with lung cancer or any type of screening is that you have to actually screen patients for programs to be successful, and we know from other screening programs, whether cervical cancer, breast cancer, or colorectal cancer, that the rate of screening is never 100%. These are rates, of different screening programs, and some are reasonable. Breast cancer 72%, cervical cancer 83%, colorectal cancer 58% of people that are eligible for screening get screening. Lung cancer, again, I think this has not been widely accepted yet because it's relatively new. There's some cost issues, but we think there's somewhere between 6,000 and 7,000 eligible patients in Chittenden County alone that are in that very high risk group. And again, we've screened less than 1,000 of them so far. So I think we're not capturing a lot of patients. And in order for a screening program to be successful, I think you really have to capture patients that are eligible. I'm going to talk about risk a little bit. This is something that I've seen recently, but perceptions of risk are interesting. I don't know if anyone followed this, the dangerous selfie thing. So people are taking pictures of themselves in dangerous situations. This is, running of the bulls. Gentleman taking a picture of himself with a bear in the background. So there's been a number of deaths when people taking pictures of themselves in dangerous situations. And in Russia, they actually started a public service campaign to warn people about the dangers of taking a picture of themselves in a dangerous situation. Like, don't take a picture of yourself with a weapon off the edge of a cliff or in front of a train. When I talk about lung cancer screening, it's really one of the things that's important is that patients and doctors understand what are the risks of smoking and what is my risk of lung cancer? It's a difficult question to answer, but one of the things I think we don't do very well is tell patients what their actual risk is. This was a study by Weinstein, and it looked at what the actual risk, so this is relative risk based on how many cigarettes you smoked a day. So the risk goes up as the more you smoke. And if you ask patients what their risk is, not only do they underestimate it, when people smoke more, they underestimate it even more than that. So we know this. This is problematic at many levels. You know, patients are sometimes motivated to quit. They don't really understand what their actual risk is. And I think doctors often don't tell people what the risks are. I think we're more inclined to give good news than bad news. And to be honest with you, it's very difficult to tell someone exactly what the risk is. It's difficult to estimate. And again, sometimes it's challenging to give. It's challenging to give bad news and to tell someone they're at very high risk. It is important as a motivating tool, I think, for people to understand their actual risk, not only to quit smoking, but also to consider screening. I think this is the most important graph in the whole talk, and something I really want to really highlight is really this issue of former smokers, and what is the risk if you're a former smoker of lung cancer. And just to explain this briefly, so this is the death rate per 1,000, and if you just look at age, so if you're a non-smoker, your risk of lung cancer is very low. We know that there are people that get lung cancer that are non-smokers. There's a certain type of lung cancer that's fairly prevalent in young to middle-aged women that occurs. There are genetic risk factors for lung cancer. Overall, if you're a non-smoker, your risk of lung cancer is very low, but as you get older, it goes up a little bit just because of pollution and other inhalants, secondhand smoke, other things. So if you continue to smoke, your risk goes up on this curve if you're a continued smoker. Again, this is a risk of death from lung cancer. And if you stop smoking, you basically get off this steep curve. And it depends on what age this is, obviously, but if you stop at a younger age, your risk continues, but it doesn't go down to the level of a non-smoker. I think this is actually a fairly big misconception or misperception, is that if you stop smoking, your risk goes back down to a non-smoker. That's just not true. It's not the case. It's something that we need to be aware of as providers, that we tell people that, you know, you smoked, it does elevate your risk. You've stopped the increase of your risk, but you're still at a relatively high risk. And again, that really depends on the age that you stop smoking. Former smokers completely underestimate this concept. If you ask former smokers what their actual risk at, very few believe that they were at an increased risk versus an average person. They just don't understand that this is, and I think this has not been well promulgated, that this is a risk factor if you were a former smoker. When I used to give this talk before the insurance issues resolved themselves, cost was a big issue with regards to the coverage of it, whether there was an out-of-pocket expense, what was the actual charge for it, would people pay for it out of pocket. Now the topic has really shifted more, is this cost effective to society in general? And so the analysis of the cost of that lung cancer screening trial has not been published. There's a very large effort to look at the cost analysis of that trial, and it has not been published. There have been some smaller series that have been published, and this is one of them. It's an actuarial analysis that was done looking at lung cancer screening applied to the Medicare population to see if it would be cost effective. This is just a theoretical actuarial analysis of that based on the data from the lung cancer screening trial. And what they found was that if you did a cost analysis on an actuarial basis, that lung cancer screening was cost effective. The cost to save a life was about $19,000, which is pretty good for a screening program, and it falls into the equivalent range of something like seat belts or something of that nature. And the cost per individual was fairly low. I think it was like $1 a day. And they estimated that there would have been a huge, if you had applied that to the Medicare population, there would have been a huge increase in lives saved. Hard to read this, but it was something like 358,000 individuals with current or past lung cancer would be alive in 2014, a very large number. So that was an actuarial analysis. I said this is my disclaimer on being opinionated, but when you look at costs, also one thing you have to consider is there's a cost of the test, the CT scan. There's a cost of the treating the lung cancer, diagnosing the lung cancer, treating the lung cancer. But what's often not talked about is what other money is coming into the system based on tobacco and smoking. So if you look at, this is the price of a pack of cigarettes from 1964 to the mid-2000s. So the price has gone up astronomically. This is the price that the cigarette companies, this is based on their profit margin and their cost, that has gone up, but the amount of taxes have also gone up dramatically. To no one's surprise, the cigarette companies are still making a profit. They're doing fantastic. But we've also have a lot of revenue that's coming in generated from cigarette taxes. And if you look at those numbers, it's pretty shocking. I don't know if people are familiar with the tobacco settlement program. So this was in 1998, I believe. The major tobacco companies at that time settled with each individual state, and they basically came up with a series of agreements that they would pay a certain amount of money on a yearly basis to each state to compensate for some of the healthcare costs related to tobacco smoking. So the blue line here is how much money comes per state from the master tobacco settlement. So that's money that's generated from the sale of cigarettes to the tobacco companies that the cigarette companies pay to the states. And the blue line here is tax revenue from cigarettes. So this is basically per state how much money comes in from the master settlement agreement and from the state. And it approaches, over a year, it approaches close to $25 billion in revenues generated from the master settlement agreement and from cigarette taxes. It's a huge amount of money that comes in that's generated from that. This black line is of interest. So this is what the CDC recommends that states spend on tobacco prevention programs. And this is what they actually spend. So there's very little, and this graph illustrates that. Of the $25 billion that comes in every year from taxes and from the master settlement agreement, the CDC recommends that the states spend $3.3 billion on prevention, basically, and they actually spend only $490 million on prevention. So for every dollar, we spend about 2 cents on prevention. I'm on the soapbox here, but basically what's happening is that this money that's coming in from tobacco is being used for general budget things. A lot of it goes into healthcare, some of it goes into bridges, roads, pensions. This is used as general funds for states. And so, 0 cents go into right now for screening. So when we talk about cost, I think we really have to consider that there's a big picture. There's a lot of money that's being put into this is tobacco alone, this is tobacco taxes and from the master settlement agreement. I'll go over this kind of quickly. I alluded to our false positive rate or the overall positive rate. So what we've done in the screening trial, the threshold of a nodule that was found in a screening trial was 4 millimeters, and we've raised that to 6 millimeters. This was based on data that was published analyzing the lung cancer screening trial, that if you raise the threshold on the nodule size, the positive rate goes down, but the death rate stayed the same. So that was from a retrospective analysis. That's been incorporated into the ACR LungRADS lexicon, and there's a benefit when you do that. There's a benefit in the positive rate, and then there's a cost benefit based on follow-up scans. So that's what we've done. It's based on retrospective analysis of the data. But I think looking at that, I think it's a safe thing to do, and it has some benefit in how many of these tests are positive. What do you do with the anxiety? This is, I had an opportunity. I wanted to play the video, but I didn't get the internet. We had WCAX came to our hospital, and they wanted to do a story on lung cancer screening. And I had a hard time. I found a patient who was willing to basically have the reporter follow her around that day. She came for lung cancer screening, reviewed her scan. Thank God it was negative. But it's funny when just seeing that process, it's an extremely anxiety-provoking process to have a test order. You know that you're at risk for lung cancer, even if you underestimate it. You're having a test done. I think a lot of smokers think that they probably have lung cancer or may have lung cancer, and just to see that process unfold was really eye-opening for me. I really thank, I won't mention her name, but I really thank the one for doing it. It was a nice piece. She was a smoker. She's quit in the past, smoking a very little bit now, and it's just the experience for her. She told me it was an incentive for her to quit, knowing that she didn't have lung cancer. So I think the screening both can provoke anxiety, but can also be a venue to help with some of the smoking cessation. I think with anxiety, you have to have a program, you have to have resources. And so, patient education is really important, that most positive nodules, if we call it positive, it's at very low risk of lung cancer, and that most nodules do not need biopsy. That's absolutely true. We need to provide results in an understandable and non-anxiety provoking way, and we really need to offer prompt evaluation and treatment when we are concerned. So those are our ways of lessening anxiety in the screening. But again, I think this is, by its very nature, screening is very anxiety provoking, but we just need to do the best that we can to reduce that. I don't want to spend a lot of time on radiation. I do want to say as a radiologist that I think the risk of any risk related to the screening test is very, 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 very small. And I say that having an experience with diagnostic imaging and the doses that we're using. So a low-dose CT scan for lung cancer screening is 1 millisievert. That's a unit of measurement of radiation exposure to the body. To give you a frame of reference, the general exposure that we get from the atmosphere, cosmic radiation, some of the terrestrial radiation, is 3 millisieverts per year, so it's a third of what you would get from background radiation. It's a very low dose for a CT scan. In my job, I'm allowed up to 50 millisieverts per year of radiation exposure as a radiologist, and that's 50 times what a screening study is. Now, that's not all at once; it's over a year, but these are very low doses. The risk to patients, even in annual screening, is very low. At this level, I feel confident, and many societies feel very confident there's no risk to patients with this low dose type of screening from a radiation standpoint. A couple of minutes up. One of the other things that comes up is the follow-up issues and some of the liability issues. Follow-up to me is really important in this program because it's high-risk screening. So even if a patient had a screen and we call it negative, category 1 or 2, we still want them to come back for that follow-up the next year while they're in that high-risk group. So we're going to send a letter. We're going to call the provider's office. We don't want to harass patients or harass the offices, but we do need some mechanism to capture patients to come back, particularly when we recommend a follow-up in a shorter interval than a year, but also for those yearly follow-ups. That communication needs to be fairly effective. We try not to disrupt the flow of offices. We tend to call physicians only when we have a positive result, and then come up with a plan for providing care for that patient. I haven't been able to do this very well. There's not a lot of good educational materials that we have for offices. The National Cancer Network produces a pamphlet on lung cancer screening. It's very difficult to use. It's a very large booklet, and that's an area I'd like to improve, of having some educational material. We are offering, when we do our intake for the CT scan, we do a short questionnaire, and then we do have information for tobacco cessation programs that we talk about with patients when they come for screening. I throw this out as a question: if you don't order this test, does that increase your liability? If someone's at risk, seeks screening, and is declined based on the physician's assessment of this, saying that no, most people don't have lung cancer, there's a lot of false positives, does that increase your liability if they do have lung cancer? That has never really been tested on a legal matter, but my point in talking about this is that the shared decision making is important, and I think it's, on the physician side, it's important to have the most accurate data when you talk to patients about whether they should proceed with screening, and not, so like I said, when it came back to things like the radiation dose, my personal opinion is I would never counsel someone to not do this test because of a fear of radiation dose. The risk of lung cancer is much, much, much greater than any harm that could come from the test. So the other question that comes up is, what if a patient is not within that risk category? So if they've smoked less, or they're not in that age bracket. And so this is difficult. My sense on this, there's a lot of other exposures that are risk factors for lung cancer and some genetic things that are risk factors for lung cancer. So if you feel that a patient is in a high-risk group but not in the highest risk group which has been approved, my sense is that you should think about lung cancer screening, particularly if the patient is very concerned about it and they have some of these other high-risk exposures or prior history of lung cancer in their family, asbestos exposure, those kind of things. The only problem with this is insurance may be an issue, but I think if these are well documented and they're out of the screening, I think some insurances may approve this. We're sort of counseling patients if they don't. If someone orders a screen, we do it. We counsel patients that the insurance might not cover it if they're not within the screening parameters that have been set up for insurance. People that have had prior lung cancer, this is a very good indication for someone who's had lung cancer and is in remission to be in the annual screening because they remain at high risk for lung cancer. They're one of the highest risk groups for lung cancer. That's basically it. I had a couple of editorial thoughts to conclude with. One is that 50% of lung cancers are diagnosed in former smokers. We want to do everything we can to get people to quit smoking, but even if everybody quit smoking today, we would have a lung cancer problem for 30 or 40 years. And so we do have to be cognizant that a lot of these are former smokers are at very high risk, and that really should be offered screening if they're in the high risk category. This screening is secondary prevention. If someone has already quit, there's no other primary prevention. It's really secondary to prevention to prevent death from lung cancer. The high-risk group is fairly high risk. 1 out of 100 patients will have lung cancer in this group, so it's high-risk screening. You need to do 320 screens to save one life. And again, just a little bit of a political statement. A lot of patients that are eligible for screening currently started smoking prior to the 1964 Surgeon General's report that illustrated the connection between smoking and lung cancer, and many of them are former smokers. So again, I think a lot of us have from a health standpoint, I think as a physician, it's antithetical to health to smoke, and a lot of people have trouble with people that smoke, because there is a perception that there's a conscious reason that people smoke. People choose to smoke. Obviously, that is complicated by many factors, most important of which is one of the most addictive substances on the face of the earth. And it's very difficult to quit smoking, and there's a lot of reasons that people start smoking. But I think when I've started getting involved with lung cancer, I hate smoking, but I don't hate smokers. I think this is a societal problem. We choose to make this a legal substance, and one of the ramifications of the making this legal is that the health issues are something that we have to deal with. The same thing is going to come through with marijuana legalization. There's going to be a health cost associated with that. There's going to be a societal cost associated with that. There's going to be money that's generated from that. It's going to be the same issues that we see with smoking. Again, I apologize for some of these editorial thoughts. I've been fairly involved in this for many years, and I'm very excited about this screening program because I do think that we're making a difference in detecting lung cancer. And I really appreciate the opportunity to talk before this group in particular. So thank you very much. Do we have time for some questions or comments? Sir?
In the populations that you're referring to as far as prior smokers and people with like lung cancer history, et cetera, I'm thinking in terms of my category of risk. I'm a former firefighter.
Sure.
And I know a lot of people have heard of just that one incidence of exposure from 9/11.
Right.
How many first responders became lung problem, including cancer victims. And,
sure.
There have been reports through the NFPA, National Fire Protection Association, talking about the health for first responder firefighters, men and women, about their day-to-day work being exposed to some of the risk factors you're talking about on an average basis.
Right.
Kind of a fire or exposure to chemical things.
Yeah.
There is, to my knowledge, no standardization from the NFPA
Right.
regarding to screening for lung diseases of all kinds, including cancer.
Right.
Is
Yeah.
that a thing that you might want to look at?
Yeah. My background before was a radiologist. I was in the I was a Navy physician, and I had a lot of experience with the asbestos exposure programs that the Navy instituted because of things that you're talking about. People had occupational exposure to substances that were known to be dangerous, and in that program they instituted a surveillance program. They were using chest x-ray, which was suboptimal, but your point is well taken, is that there are other risk factors in addition to smoking. We don't have, there are some risk models that have been developed now to look at what if certain exposure risks are, putting in your age, smoking history, possible occupational exposures, and coming up with a risk model. Those are not precise, but I think ultimately it's really, if you have a concern based on your occupational exposure, I think it's important to talk to your doctor or to see a pulmonologist to say, okay, what is my, to the best guess, what is my risk exposure, and would I benefit from screening? I think those are difficult to estimate, to be honest with you, what someone's actual risk is, but we know that certain occupational hazards are very prevalent and are a risk for lung cancer. As you mentioned, firefighting is one of them. Yes, ma'am.
One thing, I'm trying to incorporate this, when I do my manual physicals and the gym, I'm trying to incorporate this history, and your mammogram and head screen.
Right.
I am curious about why 55 is the age.
So,
I've ordered a lot of times, and then secretary comes back and, nope, they're too young.
yeah. So the age guidelines that were determined. So when they started the lung cancer screening trial, they tried to they did an epidemiological assessment of lung cancer, and then they came up with what they thought was a very high risk group. And so from the epidemiological assessment, that was where that age range came. So 55 to 74 was what was in the trial, and then they came up with a certain smoking threshold. So that was based on epidemiological assessment of people with lung cancer when they were diagnosed. What was sort of it basically was, it captured 1 to 2 standard deviations of that curve. That's how they came up with the numbers for it. And so then that number got extrapolated by the U.S. The Preventive Services Task Force. It's been modified a little bit by Medicare, but that's where that number came from. So I think of it, that's the highest risk group. When you look at lung cancer epidemiologically, that's the really high risk group. But as you mentioned, a person who smoked 50 pack years but is 45 years old, how does that factor in? So it really becomes more of again, coming back to the risk profile, that person might be at very high risk based on their smoking history, but they're not in the age criteria. I think, based on your judgment, if they think they're high risk, you may want to think about lung cancer screening. The only issue then becomes insurance. Will insurance cover it? Those are difficult decisions, I think, at this point when you fall out of those very precise ranges. But it is important to remember that's the highest risk group, but there are other groups that are at high risk as well. So it puts you in a bad position. I think that's difficult when there's such a precise range. We have had, to be honest with you, I try to look at how many cases get approved through insurance, and we have had people that are not within the parameter. We've done the scan, and some of those do go through with appropriate documentation of I feel this is high risk based on these other factors. So I think those are somewhat individual judgments. I can't make a blanket statement for every insurance policy, though, and so I think some of those do. I've looked at some of them that have come through outside the parameters, and they do get approved. Yeah. Yeah. Great. Thank you very much. Thanks.